Welcome to Medicine in Our Backyard. I'm so glad to see you all here. You've navigated that parking lot successfully. It's the precursor of wonderful things to come, so we have to be patient with it. So this is a series that is presented by the Newport Beach Public Library Foundation in partnership with UC Irvine Health. And my name is Adrienne Windsor. I'm a board member, I say emeritus of the foundation. I was on the board for 12 years and still very actively involved. How many of you are members of the foundation? Well, this is good. If you aren't, we would love for you to consider becoming a member. We have our Witty series, our Library Live series of lectures. We do the book discussion group. We have the financial workshop. We have this Medicine in Our Backyard. We do so much to enrich the community through the work of the foundation. And so it's great if you're a participant in it and want to have a sense of belonging. So I urge you, if you aren't a member yet, to become a member. Now, I'd like to thank our generous sponsors, Mike and Polly Hall. Polly just turned 91. And they were at the original meeting when this idea was cooked up, and I think that was way back in 2012. And every year they have supported this program very, very generously with their donation, and so we're grateful for that. And also grateful for Kunga Wagmo Shaw in the back. She is our program director, and Jane Merritt with UC Irvine Health. Those two women do a tremendous amount of work to bring this program to us and to see that everything runs smoothly. So we do thank them. So this will conclude with a Q&A, and I will be going around with a microphone, so please save all of your questions to the very end. If you haven't silenced your phone, please do that now. And I would like to introduce tonight's speaker. Dr. Jin Kim is a board-certified UCI Health cardiologist who specializes in heart disease and non-invasive cardiovascular imaging. Her clinical interests include women's heart health and structural heart disease, including aortic stenosis. Dr. Kim earned her medical degree as well as doctoral degree in biochemistry at the University of Rochester School of Medicine and Dentistry in Rochester, New York. We were just comparing notes on the attitude toward weather. I grew up in Michigan, and she said she was surprised so many people came out in the rain, and I said, oh, it's just a little rain. And she said, I know you're not from here. Dr. Kim completed an internship and residency in internal medicine at UCI Medical Center, followed by a fellowship in cardiovascular disease, also at UCI Health. She just told me she's been at UCI for 24 years, and I said, oh my goodness, you are so much older than you look. So please join me in welcoming Dr. Kim.
Thank you for the very generous introduction, and welcome everybody. I'm so happy to see all of you, and all of you guys look amazing with rain outside and 7 p.m. on Monday evening. So I'm glad that you're here. This is a topic that's really near and dear to my heart, and I hope that this will be providing some useful information for your health. So I'm going to be talking about personalized approach to heart health focused on gender difference. So now I'm just going to throw it out there to the audience. What do you think is the number 4 leading cause of death in 2022? Everybody. Just shout out. Okay, I heard pneumonia, lungs, COVID. Yeah, so somebody got it right. How about number 3? We're going up the ladder here. Heart disease, okay. Number 3 is unintentional injury, so accidents. Number 2, cancer. So, ta-da, the number 1 reason or number 1 leading cause of death must be heart disease. Yes. So this is one of the reasons why I'm here talking to you. In fact, I want to emphasize that heart disease kills more people than all cancers combined, and by a wide margin. And this is a pattern and statistics that's been continuing for many, many, many years, unfortunately. And when I Google having a heart attack, the top 10 images that come on board, I just copied and pasted it for you. The top 10 images, all men except one, the 10th person was a woman. So does heart disease really affect men and women to a different degree? Well, we're gonna find out. And the answer is no. The bottom line is that for both men and women, cardiovascular disease is the number 1 killer. And this actually is translating to 1 in 3 deaths for women each year. And this actually translates to 1 woman dying of heart disease every minute or less than every minute. For both men and women combined, it's 1 in every 30 seconds. It kills, just like in men, all those men, 9 men in the picture, heart disease, the official diagnosis is a cardiovascular disease, kills more women than all forms of cancer combined. It's not breast cancer that kills a woman more, it's the heart disease. And uniquely, women can be affected by some form of cardiovascular disease at any age. And this really saddens me to see these statistics, but this is a published data that the awareness that women have that heart disease is a leading cause of women actually went down over the last 10 years. So I'm not sure if this is gonna work, the pointer is not working. Okay, so the white bar is back in 2009. About 65% of women that were surveyed knew that heart disease was a number 1 killer of women. Then same survey went out 10 years forward in 2019, and now we have less than half women surveyed that realize that cardiovascular disease is a leading cause of death in women. This is really alarming. And because this is a pattern that we are looking at, so this is death attributed to heart disease. And you can see back in the 1950s, there was a great increase, and there's a great campaign about the cardiovascular risk and what we need to be healthy and et cetera. So the trend was coming down. The death attributed to heart disease was coming down a little bit, but now last several years, that is going up again, unfortunately. And this is also very worrisome statistics because heart disease is a very modifiable disease. You can make a difference. So as far as the risk factor is concerned, there's a multiplier effect. If you have a 1 risk factor, it doubles your risk of heart disease. If you have 2 risk factors, it quadruples your heart disease. And if you have 3 or more, it increases your risk tenfold or higher. But the good news is that if you know your risk factors and you modify them by just sensible stuff, you eat right, you're physically active, you don't smoke, and you keep a healthy weight, then you can actually lower the risk of heart disease by more than 80%. So heart disease, even though it is a number 1 leading cause of death in this country and worldwide, it is 80% preventable. We just don't do enough about it. So these are the common things for both men and women. So what are the cardiovascular risk factors that you need to know? So there are big 8 things that you will need to keep in mind. So I call this sleep hygiene. It's kind of a fun expression, but it's basically sleep health. Not smoking, controlling your blood pressure. You should know what your blood pressure is. And it's amazing how many times when I ask my patient, like, oh, do you check your blood pressure? Like, no. But they all have the machine, but they don't make use of it. And it's great because blood pressure machine gives you the vital signs, the blood pressure and the heart rate. And sometimes some of the fancier ones can even give you whether you're having irregular heart rhythm or not. But the blood pressure and heart rate is what sustains your body. So it's good to know that you know what your blood pressure is. You should know what your cholesterol is, and it's not just one cholesterol. There are many different molecules of lipids and cholesterols in our body, and some of them are just really bad actors. So you should know what those are. Weight, and what is your blood glucose? What's your risk for diabetes? Diabetes is sort of it's a very strong risk factor for heart disease. Exercise and healthy diet. So these are 8 sort of big umbrellas of cardiovascular profile that you will need to keep in mind. So those are the common things for both men and women. Now, can you tell me which is female? No? How about now? So we're going to now get into a little bit of differences for men and women in heart disease. What are the gender differences? So types of heart disease that are predominant in women, when I say predominant, like I'm talking 70 to 90%. Stress cardiomyopathy, you might have heard this term broken heart syndrome. So the stress cardiomyopathy, if you have a stress cardiomyopathy, it's 90% women. And we don't know why. We really don't know why. And it's typically triggered by a very severe stress, whether it's emotional, physical, situational, etc. INOCA. So INOCA basically is that you have objective evidence of compromised blood flow to your heart, but there's no blockage, there's no plaque in your heart arteries, and yet you do it. And there are many different mechanisms as to why they might be physiologically, but more women tend to have INOCA. MINOCA is when you have INOCA and you end up having a heart attack. There's actual damage to the heart muscle, and more women have MINOCA. And SCAD, spontaneous coronary artery dissection, is that your arteries are totally normal in your heart, but they tear. So the layers of different walls of the artery that makes up that wall of the artery, they just tear apart, and I'll show you the picture of that later. And again, that is like 80% women, and we just don't know why. And a lot of this, SCAD cases affect young women who are pregnant. Heart failure with a preserved ejection is a common expression when your heart pump is not working. But it's not working not because it does not contract well, it contracts well, it just doesn't know how to relax well. And that when this condition was first discovered, they thought there's so many women presenting with this condition that they just thought that, okay, sex, gender is just one risk factor to this condition. Rheumatic heart disease, another very treatable, very preventable condition that affects young women and children worldwide. In fact, it's actually the #1 cause of death of young people worldwide. Not here, not in developed countries, but worldwide. It is a big problem that can be preventable and treatable, but it affects more women disproportionately. And then POTS, paroxysmal orthostatic tachycardia syndrome. It is a benign condition, relatively speaking, but it also affects more women. Even though the prognosis is benign, it's causing a lot of symptoms, so the quality of life can be affected. So you can see just a few of the cardiovascular conditions that affect women predominantly. And of course, there are cardiovascular conditions that are unique to women because women are pregnant, they go through menopause. So you're at risk of what we call peripartum cardiomyopathy. Older women who get pregnant are at a higher risk. It's when you heart failure during or after, right after the pregnancy. Of course, there's a lot of cardiovascular risk factors that are being altered when you are going through menopause and after menopause. And even when we're talking about just one condition, heart attack, women present differently. You saw those 9 pictures of men just kind of like just grabbing their chest and having a chest pain. But women, and I don't want to generalize too much, but when they take a survey of women who are having heart attack, what is really different is that women present differently. They have a different symptoms. So unlike men, women, a lot of women have what we call aura. So they have this very non-specific symptoms like within a week before the day of a heart attack. A lot of them had unusual fatigue, sleep disturbances, shortness of breath, and chest pain is like down in the bottom of the list. On the day of a heart attack, again, chest pain, not the most common symptom. It's a shortness of breath. Chest pain number 2, weakness, fatigue. So this is contributing to not making the right diagnosis because it's confounding. When you have these symptoms and you go to the ER or you go to your doctor and describe this, heart attack is not the first thing the doctor is going to think about because women present with what we categorize as atypical symptoms. So how does a heart attack actually happen? The one most common form of a heart attack is this. So coronary arteries, that is the arteries that are feeding the heart, delivering the oxygen and nutrition to the heart muscles and heart cells, so your heart can work well. They sit on top of the heart, and then those arteries kind of branch out to smaller branches, and they get embedded into the heart muscle, and they get down to the heart cells to deliver what they need to deliver through those blood vessels. So coronary arteries can form plaques, as you see in the picture on the left, inside the artery, that yellow, junky, dirty stuff. They're all kind of getting deposited in the forms of a plaque. And when those plaques get ruptured, this is what you will see. So one artery called LAD, and there's a plaque that you can see. You can see the red blood cells going through. And then this vulnerable plaque is something is going to happen, and then it'll start rupturing. And that's how heart attack can happen. So plaque rupture. So it has 2 components. One, you need to have a plaque. And then the second is that plaque somehow becomes unstable and it ruptures, and then it leads to whatever all the yellow, junky, lipidy, cholesterol stuff. They're very inflammatory to the blood. So when the red blood cells and the white blood cells in the blood are exposed to that content within the plaque, that's when it starts forming the cascade of blood clotting, and it totally occludes the blood flow, and that's when you have a heart attack. So I'm going to give you, it was interesting. So I just came off of a week of an inpatient service. So what that is that I take care of all the patients on the intensive cardiac care unit who come with all kinds of bad cardiac stuff. And then I'm also responsible for consults on all the patients who are hospitalized, on other services like, orthopedic service or neurology. Whenever they have any heart issues, then they call us. So I came a week of a very intense inpatient service, and while I was on service, I had these two patients, and I thought, oh my God, this is going to be such a great example to share with you guys. So I'll give you this. So this is a real life patient that I just took care of. So patient A, he's a 57-year-old male. He came in with the ED for the first time with a chest pain. He said his chest pain he used to get whenever he is physically exerting himself. He's a construction worker. At some point, he couldn't take it anymore, so he came to the ED, and we did a test, and the blood test shows that he's having a heart attack. So the standard of care is when you're having a heart attack, we take him to the cath lab so we can do an angiogram, take a picture of all the coronary arteries and fix it we need to. So this is sort of a normal coronary artery, one coronary artery. There are three main ones in your heart trees, coronary trees, and there's sort of a picture that you can see as a normal anatomical representation. This is what a normal angiogram, a picture of the heart. This is the normal picture of a one artery called RCA. And we took an angiogram of this patient, and you will see. So, even if you're not a cardiologist, I think you can see that, I'm going to see if I can stop it. Oh, I guess it doesn't let me. Yeah, this is very different. So from my laptop. Anyway, the entire artery is kind of not happening. The contrast is not going through because there's just big blockage in the very beginning of the artery, so it doesn't fill the rest of the artery. So he came in with this. So when this happens, it's just like the video that I showed you. Plaque rupture, blood clot formed, and no blood flow. So we fixed that by putting a stent. So a stent is basically sort of this metallic structure that is mounted on a balloon, and that balloon is positioned right where the blockage is, and the balloon is inflated, kind of expanding the stent. How many of you have stents in their heart? Okay. We're a relatively healthy population, that's good. And so this is a standard of care. When you have a plaque rupture causing heart attack, we immediately put a stent in so that we kind of squeeze those plaques out of the way and maintain it and keep the vessel open with the stent. And that's what we did. So now you can see before and after picture of the same patient. Before, no blood flow. And after stent went in and blood flow is restored, you see how much of the artery was missing. So this was a story of a patient who was a 57-year-old man who came in with a chest pain. And now I told you we're going to talk about some of the differences between men and women when it comes to heart disease. So in the same week, actually same day, I had to take care of this patient, 35-year-old woman, no prior history. And the other guy was a diabetic, actually. He was a uncontrolled diabetic. This lady has some cholesterol issue, which and by the way, that's also a risk factor. So a 35-year-old premenopausal woman should not be having a high cholesterol issue. That alone puts you at a higher risk because the native estrogen that we have before we go through menopause is a very cardioprotective. It lowers the bad cholesterol. It controls your blood pressure. I mean, it's amazing how physiologically, how cardioprotective our own estrogen can be. Not the hormones supplements, but our own body's estrogen. So anyway, 35-year-old having an issue with a high cholesterol is already a red flag. She already has, whether it's genetic, I don't know, but she had that. She fixed it with a change in diet. But that's all she had. But she had this chest pain. It was not exertional. It would come and rest, last a few minutes. But one time it was just going on and on and on, and she couldn't, so she came to the ER. Same thing. We did the same blood test, and it showed that she was having a heart attack. So she's now taken to the cath lab. So this is a picture of a different artery in the heart. It's called circumflex. So it's the one that is running in the front of the screen. So LCX. So that's the circumflex. And when we did her angiogram, this is what we had. So there was, you see the red bracket, that's where it's supposed to be a big circumflex running along. But what's really interesting about this is that the proximal portion, the beginning of the circumflex is nice and wide, and then it abruptly narrows, and the narrow portion is quite long. So my interventional cardiologist colleague who was doing this angiogram was astute enough to not put the stent all over this artery. What did he do instead? He actually infused a medication that relaxes the heart arteries. So he gave these IV medications that dilates the heart arteries. And then after that's done, you can see sort of the normalish looking circumflex artery of this young woman. So she didn't need stents, but what she actually had was a coronary spasm. So you can actually have a heart. I mean, the blood test showed that she was having a heart attack. You know, her heart muscle was suffering because she was so spastic that she wasn't delivering enough blood flow to her heart, and her heart was suffering because of that. Again, did not need stents, different treatments. She needed a different medication that could regulate the relaxed state of her heart arteries. And that's what she got. But women can, as I said before, have different type of coronary or cardiac conditions. So one example is SCAD, where you can see in the picture there is no plaque. You know, this is not a diseased artery, and yet just spontaneously, the tissues that make up the wall of the artery just pulls apart, and that can also cause blood clot and cause a heart attack. And again, happens about 90% in women. The other form of a coronary disease that women can have is a microvascular disease. So the angiograms that you guys have seen, that is a gold standard for us to picture the coronary artery. And on that angiogram, you know, which is kind of captured here, those are the arteries that we see. But what's actually happening in our heart is this. And you see all those microvasculature, small vessels that are embedded within the heart muscle that eventually reaches down to the heart cells. Those are not captured. So when somebody's having microvascular or small vessel disease, there's really no good pictogram. There's no good pictures to capture exactly what's going on with a microvascular disease. So if you, in that microvasculature, in effect, is responsible for 70% of heart's function. It's not those big arteries that you can see, it's actually those small microvasculatures that you cannot see that are actually doing all the work of delivering the blood to the heart. Up to 80%, 70, 80%. But so you can, if there's something wrong with the microvasculature, you can have a symptom of chest pain, shortness of breath, and etc. But when they get taken to the cath lab and we do an angiogram, we're not going to see it because it's all microvascular. So in fact, up to 50% of half of the women who are having these compromise in the cardiac blood flow are told, hey, your angiogram is normal, go home, nothing to do, you know, unfortunately. So when we cannot capture these anatomically, there's a functional test we can do. There are two forms. One is called coronary reactivity test. It's got some of the other names too, but we'll just stick with this one for now. And it's the gold standard, and that's when we actually stick a catheter into the coronary artery, just like the way we do an angiogram, but instead of taking pictures, we do a functional test of the coronary arteries and take some pressures and we see whether there's a reaction to the medications that we could use, how spastic are these arteries, how well do they relax and dilate when they need to. So we check those functionally, but even though it's a gold standard, it's a catheter-based, it's invasive. Somebody's gonna stick a catheter inside your heart to do this. So we can't just do this every day. And then the most awful thing is insurance don't cover it. The insurance healthcare is a different animal, and they don't catch up with the advances of medicine. So when I have female patients who I really believe are having a problem with microvascular disease, and I need to prove that in order to get the patients on board with the right type of medications, I would say, hey, let's go get an angiogram and a heart cath to do this. And invariably, the insurance companies will deny that. And it's just really awful situation, and it disproportionately affects women with heart disease. There is a non-invasive cousin form of this, and that's called endopath that we have at UCI. And the microvasculature, part of that is controlled by this thing called endothelium. That is a very thin layer that lines all the blood vessels in your body. So they're like a one big giant connected organ, basically. So we try to find out what is going on in your blood flow in the finger and kind of derive that to your heart vessels. Not the most perfect test, but it fits the physiological mechanism as to how the microvascular disease happens. And it's a fairly good surrogate that is non-invasive. So we can use those tests to kind of get at the right diagnosis if you're having chest pain. It's, because chest pain really could be due to a lot of different things too. And this graph is not for you to memorize. You're not going to take a test on it. But I just wanted to kind of see, it really depends on how we accurately diagnose your coronary disease. Is it spasm, or does it have a problem relaxing itself? Or is it really a plaque? So depending on the property of your coronary arteries that are dysfunctional, then we can pick and choose the right type of medicines, because not all medications for the heart are the same. So there are medications that are used for blood vessels or coronary arteries that have a difficulty relaxing and accommodating the augmented blood flow. There is an enhanced constriction, like the 35-year-old female patient that I just showed. She had a problem just clamping, up and restricting the blood flow. So it depends on what you're finding on the right test for you to kind of personalize your treatment, and that's really important to treat your conditions. So, I really believe in this. UCI is one of the centers that has a dedicated women's heart health program. And what we do is, just that we do all the comprehensive, evaluation. We have a different type of diagnostic testing. We do genetic testing. We check for all kinds of different risk factors that might not be routine. Microvascular test that's both non-invasive and invasive. So we try to have all the tools that we have at our disposal, and then try to use them the right way. So the take-home message is the heart disease, the leading cause of death for both men and women. However, so you got to know your risk factors. So those 8 risk factors we briefly talked about. These are modifiable, so 80% of heart disease can be preventable. However, there are significant gender differences in heart disease that can actually impact making accurate diagnosis, coming up with the effective treatments, and how you're going to live your life. So a personalized, comprehensive approach is very much necessary, and just more education so that we don't we don't have younger generation that are just blinded to this, because it's fairly serious. So thank you for your attention.
Thank you, Dr. Kim. I'm going to come around, and I know you have tons of questions, so.
One of them is, how we should take our blood pressure. What times of the day or time of the day is most important to take it? And I'll just do my second one. Is the Women's Heart Center, is it on the campus here, or do you have to go to Orange?
No, we have an office on Jamboree MacArthur. It's one of the newer UCI clinics. So yeah, you don't have to go to Orange for that. So. The first question is a little more complicated. So it depends on whether you're on a blood pressure medications or not. So it's a very common issue. 70% of Americans are on blood pressure medications. They're hypertensive. So if you are already on a blood pressure medication, I always tell them, take your meds, and then wait for about 2 or 3 hours and then measure them. Because we want to see the efficacy. If you're going to take something, and all meds have a potential side effects, you have to know if they're working. Otherwise, why are you taking them? So take your meds, wait for a few hours, let it be observed in your system, and then take your blood pressure. And that's the number that we need to see. If it's still elevated, then you need more meds, or you need to change something. And if that's controlling your blood pressure, that's great. So.
Hi, if you had an elevated blood test like troponin because of a stress of like pneumonia, but not a heart attack, does that mean that you're on the path of one, or is that just an isolated type of, I know without seeing a patient, but what's the correlation?
Yeah, so that's a very sophisticated question. How do you know about troponin?
Because I had an elevated level.
Oh.
from pneumonia.
I see. Yeah. So troponin actually is a part of the definition of heart attack. So we believe that troponin is very specific to the heart muscle. So if you had an elevated troponin within the right context, that's a heart attack. Now, nothing is perfect. So if you have a severe kidney disease and your body is not clearing troponin, that can also raise the troponin level. And so it doesn't mean that you're having a heart attack. Or if you had a pneumonia and that produced very severe lowering of the oxygen in your body, and therefore the heart, there's nothing wrong with your blood flow to the heart, it's just that flow just wasn't carrying a lot of oxygen, and that put a stress on the heart. So you could have an elevated troponin, but that constitutes a form of heart disease. I mean, a form of a heart attack. So.
Thank you. Oh, right here.
Hello, thank you for the information. Most of what you were speaking about had to do with blockage, but what about afibrillation? How does that prevent it, or can it be, or what kind of way can we
Thank you for your question.
That?
Yes, thank you for your question. So AFib is the number one sustained arrhythmia, irregular heart rhythm, of all the irregular heart rhythms we have, and it's one of the biggest things because it is associated with a stroke risk. And unfortunately, more women have AFib. So in fact, there's a little formula that we go by. So one of the bad things about AFib is that it is associated with stroke risk, but not everybody who has AFib has stroke. So we got to figure out, okay, who's at a higher risk? If you have AFib, who's at a higher risk of having stroke as a result? And being a woman, being female is part of that risk factor, actually. That's how strong the relationship is. I didn't go into it because this was really geared towards a few of the conditions that really are predominantly affect women. But AFib, I would say, although there's a little more women for stroke risk, it really does affect both men and women in an equal degree, just the incidence of AFib. And it is a whole nother topic. It's like, it's a whole different animal, and it's, yeah, we wouldn't really have time to like discuss it. But was there any particular part of AFib that you wanted to know about?
I just wonder if there was a way to control the rhythm.
Control the rhythm when you have AFib? Yeah, so there are medications. So one way to do, first of all, I think it would be important for you to know, to get to know your AFib specialist. AFib is such a condition that it really falls into the hands of our electrophysiologist colleague. So they are the ones who only specializes in the rhythm disorder. So make sure if you have it, you have one, a electrophysiologist. But in general, it can be controlled with the medication. It can be restored to normal rhythm by shocking, what we call cardioversion. We just kind of deliver a shock and reset the heart, hoping the heart's native rhythm will come back. And 99% of times it does come back. But there are AFibs that we cannot get rid of, and that's one of the hardest things about AFib is that there are some people who just live with it. It may just come down to that. We don't try to chase it away unless it's causing symptoms.
While we're on the subject of AFib,
Yeah.
speaking for another gender and myself, I've had cardioversion, and it worked really well. It's been 11 months, and I've had normal sinus rhythm. What are the chances are that I could get off medication?
Which medication?
Blood thinners, beta blockers.
Yeah, you're not going to get off the blood thinners unless something very specific is done. So this is why AFib needs like a whole another hour. Maybe I'll see you guys all later in the spring or something. Because, AFib is a very, very complex disease, first of all. But I like to think of like in three big umbrellas. One is the stroke prevention. The second one is symptom control. And then the third one is what we call rhythm control. So a stroke, it's a self-explanatory. We wanna reduce a stroke. And the reason you're on a blood thinner is because AFib causes heart to pump the blood in a very disorganized way. So the blood flow is very stagnant in the upper part of your heart. So then it's easier to form a clot inside the heart. And if that clot comes out of the heart and travels your brain, that's what the stroke is. So the first line of therapy is blood thinner. Let's just not have the blood clot form in the first place. So that's how we prevent stroke risk. There are people who cannot take blood thinners because they bleed in their GI, in the brain, et cetera, or they fall easily or whatever. So then if you have the right anatomy, there is a device that we can put in your heart. So heart has something called appendage. An appendage is a little pouch in the upper part of the heart where the AFib happens. That's where all the actions of AFib happens. And that pouch has no function whatsoever, but that also happens to be 80% of the time, that's where the clot is formed. So we kind of put a plug to the appendage so that the circulation or the blood in that appendage does not communicate with the rest of the heart. So if that plug is put in there right in the right way, anatomically speaking, and there's no residual communication, then you can come off the blood thinner. So in order to reduce the stroke risk, you either stay on a blood thinner or you get this plug. Otherwise, you're not going to come up. Like, once you have an AFib, and the other thing really annoying about AFib is that once you have an AFib, you're at a high risk of having a recurrent AFib for the rest of your life. So we always have to address that stroke risk, whether you're in or not in AFib.
Thank you.
I have a question. Do you recommend or have any thoughts about wearables like Apple Watches or other devices in terms of heart health?
Yes, yeah, I would definitely. Like, I sometimes sound like an Apple spokesperson because unless unless I get the sense that my patient gets really anxious about just the data they're getting, I think it's a great technology we have that we didn't have before just a few years ago. So for example, in AFib, even with the earlier versions of Apple Watch, like 7 years ago, what have you, we knew from research that they were about 84% accurate of detecting AFib. And I told you, people can have AFib and be symptomatic, or not have any symptom, have no idea AFib is going on. But even if you don't feel it, you're still going to be a sitting duck in terms of stroke risk. So you got to know whether you're having AFib or not. So Apple Watch, for people who are at risk of developing arrhythmia, it's a great tool. So you had a cardioversion, but like I said, AFib can come back anytime. So it's a great idea to have that. If you, I'm like, I don't go around and tell people, hey, you have to spend $1,000 or $700, however much it costs to have an Apple Watch, for no reason. But if there's a really great indication for continuing monitoring, I think it's a great idea. And we have detected or diagnosed new onset AFib just from the Apple Watch. Yeah.
I have a question. All along, I thought that HDL, or good cholesterol, is good, but lately I have read
Yes.
that it's now a risk, for
Yes.
dementia. Thank
Oh
you.
my God, you guys are so educated. Like, you're bringing all the topics. Okay, so yeah, you're absolutely right. And this is why we benefit so much from continued research. I mean, this is why I'm in academic medicine. This is why I'm a big believer of our research. This is why I did an MD PhD. I mean, we have to continue to research. So HDL, we knew that it's a good cholesterol. So we thought, okay, hey, why don't we give patients who have a heart disease risk, and why don't we give them a medication that's going to raise the HDL for like postmenopausal women, premenopausal, you have a lot of HDL and lower LDL, which is the bad cholesterol. And then once you become postmenopausal, the ratio shifts. So you have a less HDL and more LDL. Same thing for men because they have testosterone that causes that. So they actually did a research. They gave a group A medication that is very well known to raise the HDL, and then group B, they didn't get it, and they studied, and it turned out that raising an HDL doesn't do anything to prevent heart disease. It does not give you that cardio protection. I mean, your blood level of HDL does go up. These medications are effective in that sense, but even if you have a high HDL, it does not reduce your cardiac risk if you have other traditional risk factors. So I personally focus, I don't bother trying to raise the HDL. I focus all my energy trying to get down the bad actors, because if you have a high LDL, having a high HDL doesn't overcome that. It's no good. It's like it's useless. And we got it from a recent research. So,
Hi. You didn't mention congestive heart failure. Is that because that is something that affects men and women the same?
oh no, I did actually mention that one of the earlier slides that listed all the diseases that affect women more predominantly. That was
Okay.
one of them. Heart failure with preserved ejection.
Okay.
So yeah, there's several different types of heart failure. So there's a heart failure where heart is pumping much weaker. So because it's not contracting. You can think of a heart as a very muscular pouch. So it needs to relax itself. This muscle needs to relax itself to receive the blood, the oxygenated blood, and then it's going to contract itself to pump the blood. So it's a two phases to heart function. And for women, they tend to have the heart failure that has a problem relaxing. So the heart is not relaxing itself well. So when that happens, it does not receive the blood well. So even though it's very good at contracting, it doesn't overall, it's dysfunctional. And that's the type of heart failure that affects 70%, that affects a woman more, like about 70%.
Well, I was being treated with Lasix to keep the fluid down, but then I took a a plane ride for 5 hours. And even though I wore compression socks, it pushed me into AFib, which I had never had. And it was detected on the iWatch. And I did the ECG on there, and it said blood pressure was over 150. We can't judge anymore. You're in AFib. And pulse was 190.
Right.
And this was all from being in the pressurized cabin, I guess. So when I came back and saw the cardiologist, he said, you know, we need to go to the ER. And because it had been going for several days, I was trying with the Lasix and what else I was on. They hospitalized me and gave me huge diuretics. But they put me on amiodarone, which is supposed to help the rhythm, and then the blood thinner. But it's really hard to keep the fluids, you know, they said you can have 6 cups of fluids and 2,000 grams of salt, and all of that is really difficult. But it says it's also, can that then lead to stroke and heart attack and...
AFib can, and the uncontrolled blood pressure can. So you just mentioned the 3 things that kind of feed each other in a vicious cycle. It's the blood pressure, AFib, and heart failure. They're all related. So
I take a lot of medication.
unfortunately. So, you know, but you can do something about it. I mean, you know, reducing salt, because salt goes with water, you know, physiologically. So if you're taking a lot of salty food, our body tries to react it by holding on to as much water, because a lot of salt came in, so then they hold on to a lot of water. So you have to keep a low salt diet. That'll control your blood pressure, that'll control your fluid level, and then also it'll minimize your risk of AFib from that. So it's just simple step though. You just have to moderate your salt intake. And the wonderful thing about our body is that it does it. You know, I tell my patients, like, okay, first 3 months, you know, if you're having something delicious, that's probably too much salt. But you know, like if you do it very consistently, your palate amazingly, you know, recalibrates. So you get used to it, and then you get used to the low salt foods. So when the next time you have a bag of chips, oh my God, you can really taste that salt. So your body actually does recalibrate. So it's something that can definitely be doable. So you should do that when you have AFib, heart failure, high blood pressure, stroke, you know. So, and just simple thing of salt modification.
I have a question. How do you stop someone from having broken heart syndrome or Takotsubo heart failure? With ejection fraction ratio going down below 10% at the same time. And then kicking off clots for a stroke in the answering carotid artery. How do you stop that from happening again besides meds?
That's a very extreme example of stress cardiomyopathy. I'm very sorry to hear that. But I mean, it happens. We don't know a good way to prevent stress cardiomyopathy. And again, I just cannot emphasize enough how little we know about a lot of these very serious conditions that affect women in cardiovascular medicine, and more research really needs to be done. Stress cardiomyopathy was first described like in early 1990s. And 95% are all women. And we still don't know why it happens. And because we don't know why it happens, we don't know how to prevent it.
I unfortunately had that at 37.
Yeah, I mean, it happens at any age.
And I had it again at 42. So I'm on high blood thinners. You talk about salt. You said you can have 2,000. I can have 500.
Yeah.
And people, if you look at the diet cottage cheese or diet things, the salt intake is almost double if you just ate the regular one. So that's just some little tidbits of knowledge, and even with soft drinks.
Yeah.
Thank you. Hi. How are you? Thank you so much for coming tonight. I actually have the opposite.
Uh-huh.
My daughter and I potentially both have POTS, and so
Uh-huh.
I was very interested to see that listed on there.
Yeah.
So both of us are going to be going in, but we've both gone to our general practitioners previously for different things. She thought she had vertigo. We've got some of the same symptoms. She's 20, I'm 60. And this has been going on, and we think it might be hereditary because my mom also has some of the same symptoms, and her dad had some of the same symptoms. So what we're finding, though, is when we go in and talk about these with different physicians,
Yeah.
they're not putting it together.
Right.
And it's because she most likely has ADHD. We're still getting her tested for that.
Uh-huh.
But that can sometimes be a factor along with ADHD. So my question, after saying all of that, is what would you suggest we say to the physicians to make sure that we get the correct tests to find out if we do have POTS, and if we do, what would be the best treatment for that?
So to find the best treatment depends on how accurate the diagnosis is going to be. So the diagnosis of POTS is made based on the history and objective data and on a specific test. And that test is called tilt table testing. So POTS is very specific, narrow definition. You don't drop a blood pressure when you're upright, and when you're forced to be upright, your heart rate goes up. So if that happens, and if you truly have POTS, then there are medications that addresses the inappropriate rise in the heart rate, and that would be the right therapy. So.
And just to go along with that, I also have bradycardia.
Mm-hmm.
So if I have bradycardia and they're kind of lower with POTS, would that be a conflict?
Well, the definition of POTS is that you have a high fast heart rate.
That only happens sometimes, like
Mm-hmm.
when I'm resting, I have bradycardia.
Mm-hmm. Resting bradycardia is okay. I mean, as long as you're not symptomatic, unless it falls down to like 20 beats per minute, like I wouldn't really worry about it. Yeah, it's probably not going to cause any symptoms.
I have a question. You talked about Apple Watch.
Yeah.
Now, I have tried an Apple Watch. My doctor wanted me to get one so I could monitor myself, and it did not work. And then I got the Cardia card.
Cardio Mobile,
The
yeah.
Cardia Mobile, and that first one didn't work. Now, I just got, he said to try the one that is 6L, and I just got that, and I was trying it this afternoon, and I can't get that to work. So is
I
there...
mean, what is it trying to catch, though? What to monitor what?
EKG.
Oh, okay.
Because I do get a fast heart rate.
Oh, I see.
But by the time I get to the emergency room,
It's gone,
It's
yeah.
come down.
Okay.
And so he doesn't have anything to look at. So we were trying to go that route. Would there be anything else you could suggest?
I haven't heard of people what do you mean it doesn't work?
Every
Like
time I do it, it says that the reading is incomplete, that there's too much noise.
Huh. Okay.
Whatever that means.
In that case, you might be a perfect candidate for what we call LinQ. There's an insertable loop recorder. So it's basically, you know how you wear heart monitor outside, Apple Watch outside, Cardio Mobile on your fingers. But there is there's a monitor that can be inserted right under your skin. I know it doesn't sound really great, but it's actually a very quick 5-minute office procedure. And it just goes right under your skin, right over your heart. So it's got a lot better diagnostic accuracy. So it's less movement dependent, number one. And second is that it's more accurate because it's closer to the heart, so we get less noise. And number three, it's good for 3 years. So for patients, I mean, doesn't sound like your case, but there are patients who we suspect to have a pretty serious irregular heart rhythm, but it only happens like once in every 6 months, so it's not going to be good for heart monitors and et cetera, and then they may just pass out and can be pretty grave. So then we would use this because it'll always be there, and then we can capture these rare instances of significant arrhythmia that we need to know. So that's something for you to consider. I don't know if it's, if you really needed that to that extent, but.
Well, and it just seems like I have had incidents closer together. Before they were very irregular, but I had one in December, and I just had one this last weekend. And so I've had testing in between. So I was just concerned.
Yeah.
Thank you.
Over there.
Hi. There seems to be a protocol for, excuse me, people with heart issues, male and female. You're put on, statins, you're put on, calcium channel blockers, beta blockers, all this kind of stuff. Have you found as between men and women that the response is different?
Yeah.
As to dosage and types?
The types in general. I mean, I'm generalizing a lot, but in general, men don't like a certain type of beta blocker. It does make them feel more tired. It can also cause erectional dysfunction. And because I'm a female doctor, they might not be completely forthcoming talking about it. And some do and some don't. So there's that. Some men do have a little difficulty getting adjusted to the beta blocker that is very much needed for their heart condition, but they may have some hard time with it.
I've had personally that, trying to titrate dosages on various medications.
On your own, you mean? Mm-hmm. Okay. So there's one advice I want to give you. The blood pressure is one of those things that's very dynamic. So one moment it can be high, another moment it can be low. And yeah, you should be able to sort of modulate the dose as you see fit, because doctor's not there with you at your place. But if you're going to make a change, please communicate that to your doctor. I mean,
I'm compliant. I let the doctors know. We discuss it. I chart everything. But I just found that some doctors say, well, I know, but the studies say that you should take more of it, or you should add aspirin in addition to antiplatelet therapy. And that just, I argue with them, I guess.
Yeah, it depends. It really depends on indication. There are certainly instances where you need to be on both aspirin and another antiplatelet therapy. So it really is very context dependent. I tend to be very data driven. So if there's a research for that specific context, I can honor that, or et cetera. So that's a one general rule of thumb. But then within that, I talked about personalized approach. I rather know about a patient who's going to let me know that he or she cannot take a certain medication, even though it may be indicated for the conditions they have, than have them non-compliant with the medication and I don't know about it.
Oh, yeah. No, I just find that personally, it's kind of anecdotal, my own personal survey, but I see that as far as my own response to medication and dosages, I have to really argue with the doctor and discuss it in tandem.
Mm-hmm. Well, that's healthy. That's good.
Hi. I have a question and a comment. What caused the spasm on the 35-year-old, do you know, on her artery? And I think there was a case of SCAD last May on a 35-week pregnant woman, and they sent her home with a panic attack or indigestion. But she came back, and then she said it was a stabbing pain, and they found it. But and also, would a Holter monitor help her?
A Holter is too short. It's only but that story about SCAD is too common. So what we are finding is that, as you saw the graph where, less than half of the women realize the heart disease is what's killing them. But it's the same thing with the physicians. The awareness of heart disease being the leading cause of death in women is low, and cardiologists a little better, but then you talk to primary care doctor or surgeons, for God's sake, it's just, the awareness and the education, it really is needed in both in a community side, lay public, and physician side,
But what caused the spasms?
So there are two one, we don't know sometimes we just don't know. Certain patients do have like elevated catecholamines. It's a type of like a stress hormones that can vasoconstrict. And this is why when you're stressful, your blood pressure goes up, because we produce these stress hormones that constricts the blood flow, and then blood pressure goes up. So we all have that mechanism. Some people have like sort of too much of it, and that patient did talk about how work was a little bit getting stressful lately, and etc. The other thing is just a little bit of plaque can cause that, because you don't have to have a whopping plaque that obstructs the blood flow, but the little bit of plaque, lining of that plaque in your arterial wall will make the function of the arterial wall abnormal.
Thank you. 2 parts. What does an EKG show? And I also heard about a test. It's called calcium source. They can take pictures of your arteries and find out how much calcium buildup you have in those arteries.
Yeah, so I'm going to answer your second question because it relates to what you just said. What I just said in response to her question is that so in our heart, we shouldn't have any calcium, because it's just soft tissue, like heart muscles and valve tissues and blood vessels. So when these plaques getting built up inside the arteries, about 80% of the time it comes with a calcium deposit. And calcium just lights up like a Christmas tree on a CT CAT scan without contrast. So when we take a CT scanning and there's a calcium on the heart, we know that is in the coronary artery. I mean, there's some other parts of the heart that carries calcium, but in the coronary distribution, when there's calcium, that almost always speaks to the presence of plaque built up.
Calcium
Yeah,
/ plaque.
exactly. And that's exactly what I'm going to actually do for this 35-year-old. When I see her in the outpatient once she's discharged, is I want to know what caused the spasm. Was it totally normal artery versus does she have like a speckles of calcium already? She did have a risk factor of a high cholesterol. So, we can pick up just a little bit of presence of plaque through calcium score CT. So it's a good screening tool for detecting early coronary artery disease.
Is that something a person can ask their doctor to do for them?
Yeah, or you can just, so that's another thing about, so, we know from data that about more than half of the Americans older than 35 years old, 35, carries coronary calcium, meaning coronary plaques. But calcium scoring CT is not covered by insurance.
Yeah.
It's an out-of-pocket cost.
Wow.
So, thankfully, it's not a very involved protocol as far as the CT is concerned. It's a very quick scanning. It's a very simple test. So I don't need to have it done in tertiary academic center. I just say, go find the cheapest deal. You can just go to Newport imaging or whatever, and get it done at $99. I mean, it's out-of-pocket cost, So they just need an order from a doctor in any imaging centers. But it tells you so much about the status of your cardiovascular, disease. Because if you have calcium, you have heart disease. Your calcium score may be 20, which is very low score, but that means you have heart disease. You have 20 points worth of small plaques in your heart arteries. And the other thing is some people may have, so they have some family risk factors and they want to know what their calcium score is, and I'll get a calcium score and it's 50. And they're like, okay, I don't want to take any medications. It's only 50. I don't want to be on a statin. I asked Dr. Google about all the side effects, and, he scared me. But then, when I actually look at the scan, I told you there are 3 arteries in the coronary artery. One is a little more important than the other. And then the one that's important, the nickname for it is called widowmaker. So if I have a patient whose coronary artery calcium score is only 50, but 49 points of that 50 is all in that widowmaker, I'm going to make you take statins. What does a statin do? It does 2 things. One is it lowers the blood cholesterol that feeds into formation of the plaque, so the plaque doesn't get larger over time. And the second thing is it stabilizes that plaque. So yes, you may have a small plaque, only responsible for 49 points on the calcium score, so that's a small plaque. But once that small plaque ruptures, it doesn't matter it's big or small, it still is going to cause very powerful clotting and inflammatory reaction in the blood vessel that results in blood clotting. Causes the same damage.
Okay, and what does an EKG show?
ECG is a type of a test that looks at your heart rhythm. So, I find the heart really fascinating because it's a very dynamic. It moves, and it's got its own groove. Like I used to do basic science research, and if I take one heart cell and put it in a petri dish and I look it under the microscope, it contracts by itself. It's so cute. And so the heart has its own rhythm. And the reason the heart is contracting is because there is a electrical conductivity that goes throughout the heart, and there's all the cells are beating and contracting in unison. So that electrical conduction can be captured on ECG. EKG in German. The machine was invented by a German physician scientist. So it was an electrocardiogram, but with a K. But in English nowadays, it's electrocardiogram with a C. But people just say EKG. ECG, same thing.
So are you a believer in a program such as the Ornish lifestyle insofar as reversing heart disease if you follow a plant-based diet and exercise and meditation and group support? Do you believe that science can reverse heart disease?
Reverse, meaning make it go away?
Well, according to Dr. Ornish, his Kool-Aid out there is that if you follow this diet and the program, it will actually reverse
So that's
heart
like
disease.
that's like a little bit of false advertising. So there's nothing in the world right now, and I never say never because in medicine we have made such progress, so we don't know where we're gonna be like 10 years from now, 15 years from now. But currently there's nothing in the world that's gonna melt away those plaques that you've already built up. So the reason preventive medicine is so important, or lifestyle and medication compliance, the reason they're so important is if you have already built a plaque, the best hope is that let's not make it get bigger and let's stabilize the plaques that you have already. And the only medication that can do both is a statin right now. That's what science suggests. Ornish program is very severe regimen. If you can do it, I'm all for it because that literally just speaks to the 8 risk factors that we talked about that's going to reduce the heart disease risk by 80%. So if you can stick to it, go ahead and do it. Problem is that with any like very particular a diet or etc. If something is really harsh and severe, people just don't have the endurance to keep up, and that's the problem because heart disease is not an acute issue. I mean, if you have a heart attack, etc., it can be acute, but it is a chronic disease. So you need to have something, a regimen that works for you for a long time that you can maintain.
All right, thank you. One more question, and that will. Oh.
I have a question. Are your slides available?
Oh, I don't know.
I can answer that. The video of tonight will be online on our website and on our YouTube channel.
You're gonna hear all my Korean accents. A proud graduate of ESL.
Pardon? Yes. Yes.
Yeah, or rather, I mean, I could ask my colleague who is an AFib expert to do it. Yeah.
So we'll let Jane know that we want AFib, right?
Next
All
year,
right.
yeah. Next
Thank
year,
you,
Heart
Dr.
Month.
Kim. That's been great. All right. And as I said, the video for tonight will be up on our website and also on our YouTube channel. Our next meeting will be on March, what's today, 27th, March 27th, because we have a leap year. And it will be on the latest things in correcting colon cancer. So.